It's Saturday night and you're working in the CICU. You admit a 7-month-old with a repaired AV canal and known depressed LV function and moderate left AV valve regurgitation. He's got rhinovirus and he's tachycardic. It looks sinus. Baby received a fluid bolus and doesn't look dehydrated. He doesn't have a fever. He's calm and not working too hard to breathe. So what's going on? The problem is the temperature was taken with this thing, or maybe like this. Take a central temperature and you'll have your answer. Now, it may be that these temperature devices are just wrong and we shouldn't be using them at all in our ICUs. But even with good measuring devices, there could be substantial differences between peripheral and central temperatures in our kids in the cardiac ICU. The body has multiple compensatory mechanisms to deal with low cardiac output. One of the first mechanisms is constricting blood flow to less important organs. And your skin is less important than your brain. This is why somatic NIRS values fall with declining cardiac output and capillary refill prolongs. There is less blood flow to the skin and subcutaneous tissues. And with less blood flow, temperature measured peripherally will be lower. So your patient may have a fever, but normal skin or tympanic temperature. Peripheral vasoconstriction can also make it harder for patients to get rid of excess body heat. This may explain the low-grade fevers that patients with heart failure sometimes have, a phenomenon first reported in the literature in the 1930s. In patients with infection, this will cause an even greater difference between their peripheral and central temperature. So there's only one thing I really want you to learn to do now that you've watched this video. If your cardiac patient has unexplained tachycardia, get a central temperature.